Good evening, everyone. Welcome to the IPNA endorsed Webmaster Series 2021. It is an exclusive pediatric glomerular disease symposium, and we have successfully completed 6 webinars with a lot of successful participation from a number of countries. And the highlight of this program is having a polling session, but today we will not be having the polling session, but the questions pertinent to present topic will be taken up for polling session in the subsequent webinars. And today we have two eminent speakers. The first speaker is Dr. Susmita Banerjee. Dr. Susmita Banerjee is a consultant, pediatrics, Department of Pediatrics and Pediatric Nephrology from Calcutta Medical Research Institute, Kolkata, and the Institute of Child Health, Kolkata. She is one of the senior most pediatric nephrologists with more than 30 years of experience, and area of interest is towards nephrotic syndrome, CACUT, and AKI. And she has pioneered pediatric nephrology services in Eastern India. That's really great. And conducted and organized multiple CMEs, workshops, and conferences. And she is a past chairperson of IPNA and a section editor of Pediatric Nephrology Journal. And she is also an Indian counselor to IPNA from the year 2013 to 2019. She has a number of publications to add on, more than 40 journals, and has contributed to a lot of chapters in textbooks. Over to Dr. Susmita Banerjee to deliver a talk on IgA Nephropathy clinical decision. Over to you, ma'am.
Thank you so much. Okay. Thank you very much, Dr. Kalaivani, and to the whole team in Mehta Children's Hospital for inviting me to participate in this symposium on glomerular diseases. So I will be talking about IgA nephropathy. If you look at the literature, there's really a huge number of papers on both adult and pediatric IgA nephropathy. But when you start looking at management, whether it be individual papers or reviews, the final conclusion is always that there is a lack of good quality, large RCT data. And because of this, making generalized guidelines is difficult. And therefore, we need to have an individual patient-based approach to management. So in this talk, I have tried to focus on such individual decision making. So what do we look at? What do we think of? What do we see? What evidence do we have to back up our decisions when we are treating individual patients? So the plan of the talk is like this. I will give a brief introduction of the disease and its pathophysiology. I will talk about something very important, which is risk assessment. I will discuss the differences between children and adults. I will present an example and discuss the management of severe cases and similarly the management of mild cases. We will talk about monitoring and further management, and finally we will talk about whether anything is new that could help us in the near future. So as an introduction, let us start with the historical factors and the epidemiology. This condition was first described in 1968, and it is known as the most common nephropathy globally. However, the prevalence is widely different. It is most common in Southeast Asia, and then in Europe, and then in other parts of the world. And this is thought to be not only due to differences in genetic and environmental factors, but also in a big way, it is related to screening practices. Because some places of the world, like some countries in East Asia, there are regular routine screening practices done in school-age children, which picks up this disease very early. It is known to be a chronic progressive glomerulopathy in adults, with 30 to 40% of patients having ESKD by about 20 years from presentation. It was initially thought to be benign in children. However, that was probably because these children were not being followed up for a long enough time. And in fact, it is now known that 20 to 30% of children will have progressive kidney disease, which will become evident by 15 to 20 years. And 20 to 30% of such children will actually have ESKD by 20 years. So if you think about it, many of our children 20 years hence will be just entering adulthood, and that is a really bad time to have ESKD, dialysis, transplantation, etc. And so the point of the whole management of IgA nephropathy in children is to try and see if we can prevent this long-term morbidity and this long-term progression. So looking at the pathology, the patients who have IgA nephropathy, they have an inherited tendency to have abnormal IgA1 molecules. So they have a galactose deficient IgA1 molecule which is circulating in the blood already. When these patients are exposed to what is yet unknown allergens which come in contact with their mucosal surfaces, they develop anti-IgA1 autoantibodies. And these autoantibodies combine with the galactose deficient IgA1 molecules to form antigen antibody complexes. These immune complexes circulate and are deposited in the kidney, particularly in the mesangium. And so we have this typical histopathological feature where you have in the early stages different degrees of mesangial proliferation, which with time extends to mesangial expansion, focal glomerular sclerosis, and over years to even more sclerosis, tubular interstitial changes, tubular atrophy, tubular fibrosis, and in some patients to end-stage renal disease. The pathognomic feature of diagnosis is the finding of these IgA1 deposits in the mesangium during immunofluorescence tests. And IgA has to be dominant or co-dominant to diagnose this disease. The clinical presentations can vary. They may be mild proteinuria and hematuria, which is just picked up on routine screening. But what is very typical in children is a recurrent macroscopic hematuria, which is often associated with upper respiratory tract infections. More severe manifestations are a nephritic syndrome, non-nephrotic ranges of proteinuria, nephrotic ranges of proteinuria, mixed nephritic-nephrotic pictures, and rarely a rapidly progressive glomerular nephritis. Now, in different parts of the world, the presentation varies, again, according to how we pick them up. So, for example, in Japan, where there is the school screening program, the commonest presentation is microscopic hematuria, asymptomatic proteinuria. Whereas in Europe and other countries, where we pick up patients only when they are symptomatic, the commonest presentation is different degrees of proteinuria. If we look at long-term follow-up of patients with IgA nephropathy, pediatric patients with IgA nephropathy, and we look at reports that come from countries which pick up the disease very early through the screening programs that I was talking about, you can see that over years, 5 years here and 15 years here, a large number of patients will have full remission. But there is also a significant number of patients who will have some persistent abnormality, be it just abnormal urine analysis or persistent proteinuria, or in some cases, renal failure. So the whole challenge of dealing with pediatric IgA nephropathy is to try and distinguish between these groups and these groups. We want to treat patients who will develop progressive renal disease in the early stage because we want to prevent this happening. But at the same time, we do not want to over-treat this group. So we do not want to treat patients who will ultimately have, or we do not want to give very aggressive immunosuppressive treatment to patients who will have a pretty good outcome in the long term. So it is very important to estimate the risk of progression. And what studies have showed is that we can estimate the risk looking at two things. One is the clinical factors, and the second is the biopsy features. With clinical factors, proteinuria is one of the most common criteria that have been followed up, and the association with renal survival has been seen. And the other parameters are hypertension, reduced GFR, and hematuria. And you can see in these survival analysis curves from a study from Korea that patients with combined hematuria and proteinuria at presentation that persisted during follow-up, patients with proteinuria that did not remit in follow-up, and patients who had a low GFR which did not improve in follow-up, these are the patients who had worse prognosis. And it is not just, again, I will emphasize, it is not just these features presenting at renal biopsy, but also at follow-up after treatment that makes a difference to the long-term progression. Hematuria was not previously paid much heed to, but new evidence is indicating that the persistence of hematuria indicates that the disease is still active, and repeated episodes of hematuria can also cause a renal tubular injury and therefore can cause chronic changes which will not reverse. So the second criteria we use to forecast or to try and predict progression is the renal biopsy. And the most common renal biopsy score, the classification that is used nowadays, is the Oxford classification, which was initially suggested in 2009. It is called the MEST-C score, and this categorizes the biopsy according to presence of mesangial hypercellularity, endocapillary hypercellularity, segmental glomerular sclerosis, tubular atrophy, and the presence of crescents. And there have been several validation studies in the long term that have shown that the degree, the total MEST-C score does correlate with outcome, and particularly the M, E, and C scores. These are scores that are thought to be due to acute disease. These are proliferative indexes, and these are patients who have high M, E, and C scores are patients that may be amenable to therapy, and these are criteria, these are changes which may be reversed. On the other hand, sclerosis and atrophy, as we all know, are signs of a chronic process going on. So patients with a lot of sclerosis, with a lot of tubular atrophy, have a poor prognosis and do not respond well to treatment. Now, again, studies have shown that it is not just the clinical criteria or the histopathological criteria separately that should be used to predict progression, but it is better, the prediction is better if we combine the two scores. So combination of the MEST-C score and clinical data at biopsy in adults gave the same predictive power as seeing what the outcome was clinically after 2 years' time. And this was also shown in children that the risk factors for persistent proteinuria could be predicted by a combination of the clinical and the histopathological criteria, so that patients with M1 scores, that is significant mesangial proliferation, had similar outcomes to patients with M0 scores, but who also had proteinuria and reduced GFR. And the best outcomes occurred in children who had both M0 scores and a good GFR at onset. So we use this combination of the clinical parameters as well as the histopathological parameters to predict the risk of progression, and also to predict whether this condition may be reversible or not, and whether aggressive therapy is indicated. I think you all must be aware of the adult guidelines which the KDIGO published in 2012, adult guidelines for IgA nephropathy, which state that all adults should be started on supportive therapy for the initial 6 months if they have proteinuria over 500 milligrams per day. Along with maximum supportive therapy, RAS inhibitors should be advised, and of course, optimum blood pressure control in adults, anti-lipid agents as required, salt restriction, restriction of smoking, obesity. So very strict supportive management along with RAS inhibitors is advised by KDIGO for the first 6 months. And KDIGO says that if there is persistent proteinuria after 6 months, only then should you try steroids or other drugs such as fish oil. In crescentic IgA nephropathy, which I won't really mention very much because it is very rare in children, but KDIGO suggests that steroids plus minus cyclophosphamide could be used. Now, this was the KDIGO guidelines in 2012, and since then, there have been a couple of big trials that have looked at whether after giving supportive therapy in persistent proteinuria, whether steroids may be of benefit or not. But in both these adult trials, the addition of steroids after initial optimum supportive therapy did not provide any benefit in the long term. And in fact, in this testing trial was associated with such a high rate of adverse effects that it was terminated early. And therefore, when KDIGO revised several guidelines in 2019, they decided to leave the adult guidelines for IgA nephropathy as it is because they saw no good trials confirming the benefit of steroids at any stage. And they also suggested that a similar plan should be used in pediatrics because there was no other data in pediatrics to suggest anything different. Now, after these guidelines came out, there was a lot of concern amongst experts in IgA nephropathy in pediatrics. So the issue is do we think that IgA nephropathy in children is the same as IgA nephropathy in adults? Only if it is the same disease should it be managed in the same way. But if it is a different disease, then our management should be completely different. And what the evidence suggests is that children presenting with IgA nephropathy have a much earlier, much more acute disease. So if you look at this clinical and histopathological differences, this study between adults and children, so 129 adults on this side and 82 children on this side, and if you look at the biopsy scoring, you will see that chronic criteria like sclerosis and tubular changes were much more common in adults, whereas in children, the commonest pathological features were mesangial proliferation and endothelial proliferation. And these were significant, these differences. Similarly, when you look at the European Valiga study, which looked at the follow-up of patients with IgA nephropathy and included about 174 pediatric patients amongst over 1,000 patients totally. If you look at this, this bar, this is the total number of patients with sclerosis, and you can see the pediatric patients have much less sclerosis. Tubular atrophy also, the number of patients, total patients is much higher, in total patients is much higher, whereas pediatric patients have much lower scores. So therefore, it seems that the children have much more proliferation and much more of an acute disease. And then what happens after immunosuppressive therapy? Again, there are several studies that show that not only is there an improvement in acute acute pathological changes after therapy, but there is also non-progress of chronic lesions at repeat biopsy after corticosteroid or immunosuppressive therapy. And again, interestingly, this clinical study looking at 28 adults and 41 children before and after steroids, it shows that in children, the proteinuria dramatically reduces and eGFR overall actually improves, whereas there is either deterioration or no change in adults. Therefore, to sum up these two slides, IgA nephropathy in children appears to be an acute glomerular nephropathy, showing acute changes on biopsy more than chronic changes, and there is a good potential for reversibility with immunosuppressive treatment. So now let's come to my first patient. This is a child, 14 years old, female, who had mild edema, saw the local pediatrician, but the mild edema resolved. At that time, she had microscopic hematuria and proteinuria. And this hematuria and proteinuria was followed up, and she was referred to us because there was persistence in hematuria and proteinuria at 2 months since presentation. And when we saw her, she still had proteinuria of 6 grams per day. Her renal function was more or less normal, and she had no hypertension. So we did a renal biopsy on this patient, and this child showed this score, a good amount of mesangial proliferation, M1, endothelial proliferation, so E1. There were no chronic changes, and there were a significant number of crescents also. So M1, E1, and C1 was the total score. So this is what we would call as a severe presentation. This is a child with high-grade proteinuria with hematuria. Although she did not have hypertension or a reduction in GFR, she had a high MES-C score. So she has high risk on the basis of these factors, but we also think that the disease has potential for reversibility, given that the proliferative changes were maximum relative to the chronic changes. So what are the options for therapy in patients with such severe presentations? If we look at adult studies, looking at RAS blockade in IgA nephropathy, RAS blockade is shown to be effective in reducing proteinuria, but there was in this meta-analysis no significant effect seen on long-term renal function. There is only one pediatric study with 66 patients. This is a combined pediatric and adult study actually, where ACE inhibitors were compared to placebo, and there was a significant difference in the progression of disease and persistence of proteinuria favoring the patients who were on ACE inhibitors. So in the pediatric studies, RAS inhibition seemed to work in reducing proteinuria and maintaining renal function. The second option in treating severe patients is with immunosuppressive therapy. We have a Cochrane meta-analysis, which is very recent, including 58 studies, of which 6 were pediatric, large number of patients in total, which indicated that there was moderate certainty evidence that steroids in IgA nephropathy with high-grade proteinuria probably prevents decline in GFR. However, the majority of the studies were poor in the sense that there was insufficient evidence for the development of adverse effects, and there was no, it was not able to make any subgroup analysis to see if there were specific patients who were better, who responded better to certain drugs than others. There was also not sufficient evidence to show that any other agents such as cyclophosphamide, azathioprine, or MMF improved clinical outcomes in IgA nephropathy. So this is a mixed group of studies, pediatric and adult, mostly adult though. If we look at immunosuppressive treatment in pediatric RCTs, there are really only 3 studies, and the numbers are fairly small. Again, this is a severe group which diffuse mesangial proliferation. All these studies are from Japan, and they show a definite advantage in the patients who were given steroids or immunosuppression in comparison to the group who was on non-immunosuppressive treatment with anticoagulants, heparin, which was changed later to warfarin, and dipyridamole. So the Japanese group saw in these trials a definite advantage in giving immunosuppressive treatment, particularly steroids. There is a Chinese meta-analysis in which several of the Chinese are actually in Chinese language. So it is difficult to assess these, but this meta-analysis with different added immunosuppressives along with steroids showed that there was an advantage overall in proteinuria remission, and there was no difference in the adverse effects when immunosuppression was used. And based on all this, the Japanese guidelines, which were published in 2008 and then modified in 2015, again suggested that patients with very mild manifestations could just be treated with RAS inhibitors, but severe patients should receive steroids and immunosuppressive treatment. At that time, they had also suggested a combination therapy with warfarin and dipyridamole, but recent papers from the same group actually have said that there is no strong evidence now for the use of anticoagulants, tonsillectomy, fish oil, etc. But we need to remember that these studies are only in one specific patient group, only in the Japanese cohorts, and in other cohorts, there really are no RCTs that we can base our management on. If you look at a European cohort, which is the Valiga pediatric cohort, where 174 children were followed up in multiple centers in Europe for 4.6 years, this was an observational study, and this showed that the group that got corticosteroids or immunosuppressives, which was 50% of this total group, had a better outcome with reduced proteinuria and increased renal survival. So at this point, if I can just summarize what we know then in patients with severe disease, that is patients with high risk for progression, but who have what seems to be reversible changes, potentially reversible changes on renal biopsy. So everything suggests that in this group of patients, to try and reduce this high risk, we should use aggressive treatment with RAS inhibitors and with steroids plus minus other immunosuppressants. However, although we do have some small RCTs and a lot of observational studies, we do not have very big, strong RCTs yet to validate this impression. We do know, however, that none of these studies have actually spoken about adverse effects of immunosuppression in this group. So that till now is a benefit of so there seems to be a benefit, but no definite adverse effect. Patient 2 now, a 13-year-old male, and this is a very common presentation. This child has for over a year had episodic macroscopic hematuria with coughs and colds. When his urine is checked in between these episodes, there are no abnormalities. So there is no microscopic hematuria and there is no significant proteinuria at all. Many times we do not really do renal biopsies in such patients. However, the parents were getting anxious and it was going on for quite some time. So this child had a renal biopsy which showed IgA nephropathy with very mild focal mesangial proliferation, so M0, but no other changes at all. So this would be classified as a mild pediatric IgA nephropathy. These patients, the mild group, they usually constitute patients with episodic synpharyngitic macroscopic hematuria like our patient, or microscopic hematuria, or very low-grade proteinuria. So these patients often get diagnosed very late because many times we miss them, especially if they are having microscopic hematuria, low-grade proteinuria. And even when we do find these findings, unless the proteinuria is relatively large, so probably more than 0.5 milligram per milligram protein creatinine ratio, we do not usually biopsy them. Usually these patients have associated low scores on the MESC classification. And the general guidelines are that the general impression is that they have a low risk and need to be followed up mainly. Let us look at what the studies show. So do they have as good an outcome as we would like to believe? So this is a pediatric study which looked at 106 patients in Japan, follow-up over 6 years, very low degree of proteinuria, had presented, 54% had presented with at least one gross hematuria episode, and renal function was normal and there was no hypertension. And you can see over the long term, remission was attained only in less than 40%. So even though no patient reached stage 3 CKD, these patients have a long-term course and we do not know what will happen to them in the long term. This is only a 6-year follow-up. Other studies which have included children show similarly that full remission is very rare. So again, 40% and here 14% resolution of microscopic hematuria. So the many patients who present even with very mild features actually have a long-term disease, long-term persistence of abnormalities. Even the patients that do remit, we saw in that first study that about 60% patients had, about 40% patients had remitted. And in this study, where 96 patients with mild IgA nephropathy were followed up, patients that had not received any treatment at all, 57 had gone into remission. So about 60% had gone into remission without any treatment. But that still left about 40%, which was not in remission. And only 51% had normal urinary findings at the last follow-up of 8 years. Interestingly, amongst those who had remitted, so amongst the 57 who had remitted, a further 10 relapsed again. And when you looked at these patients, looked at the characteristics when they first presented, it was very difficult looking at their presentation characteristics to differentiate between who would remit and who would not. So there remains the worry, even in mild disease, that this disease can progress and we may have problems in the long term. Now, there are very few studies of management of mild IgA nephropathy. These two studies are prospective studies, again from Japan, looking at the use of lisinopril, and in this study, a combination of lisinopril and losartan in mild IgA nephropathy, where urine protein creatinine ratio was over 0.2 milligram per milligram. And here you see that 80% of patients went into remission after about 2 years. And this study also, about 80 to 90% went into remission after about 2 years, and there was no difference in the arms where single agent was used, just lisinopril was used, compared to the one where dual agent lisinopril and losartan were used. So the authors they concluded that you can just use a single agent, and if you compare, these were uncontrolled trials, unfortunately, but if you compare with the previous studies, which showed about 30, 40, 60% remission rate, with lisinopril, with RAS inhibition, the remission rate seems to be higher. Now, what about immunosuppressive therapy in mild IgAN? So in mild, so I'm sorry about that, that should be mild IgAN. So there is an adult study which is retrospective, which showed that steroids or immunosuppressive agents were not associated with any improvement. However, it is in adults, and the patients who got immunosuppressive therapies were already in a more severe manifestation bracket. So I don't think we can conclude anything from this trial. But if you look at the Valiga study again, you will see that this improvement in proteinuria and renal survival, which was seen in patients who were treated with steroids and immunosuppressives, this improvement was most effective in mild patients. So again, we go back to the question that are we missing treating these patients as well at an early stage? Could we prevent those patients who will progress from progressing if we treat at this stage? However, there are no prospective control studies looking at immunosuppression in mild IgA nephropathy. And therefore, for the time being, the consensus is that if these patients have a reasonable amount of proteinuria, then it is worth trying a RAS inhibition. But I don't think we are into using immunosuppression in these patients yet until we see some studies to show definite benefit of these agents. So what happened to our patients? The first patient, which I would classify as a severe presentation, we started RAS inhibition and we gave IV methylprednisolone early because of the crescents. We then moved over to oral prednisolone initially at a daily dose and then gradually changing to alternate day and weaning. And we added MMF. The addition of MMF was because there was persistent proteinuria even after a month of daily steroids, and we wanted to get down on the steroids and add a steroid sparing agent. With this therapy at 1 year follow-up, although the proteinuria has reduced from 6 gram to less than 1 gram, but there is still persistent proteinuria. This is 1 year onward. The second patient, who we had classified as a mild patient, we had no abnormalities between the episodes of macroscopic hematuria. And because of this, we thought we would observe only. However, after 1 year, this child developed gross edema, and investigations showed gross nephrotic range proteinuria, and this time even his serum albumin had dropped, although his renal function was maintained. He was started on oral steroids and had no response, and he was advised a repeat renal biopsy, and again MMF was added. So the next question is, how do we follow up these patients? It is okay to decide at presentation which one is a severe presentation, which one is a mild presentation. Are they reversible? How strongly do we treat them? Do we give them just RAS inhibitors, or do we give them steroids and immunosuppression as well? But what happens 6 months, 1 year, 2 years down the line? Well, studies show that if proteinuria persists, then renal survival is also poor. And this is both in adults and in children. And degree of proteinuria actually decides long-term outcome. But the problem is that if we have persistent proteinuria, what do we do? Do we give immunosuppression or do we give RAS inhibition? Because proteinuria and IgA nephropathy can be a feature of persistent acute proliferative changes, but it can also be a feature of chronic changes due to glomerular sclerosis, scarring, hyperfiltration, which will not change by adding immunosuppression at a later stage. There is really no way to differentiate between these two possibilities except to do a renal biopsy. And so some of these patients, like our second patient, would merit a second renal biopsy to assess what is happening over time and to decide further treatment. So at every stage, we need to estimate the risk, not just at presentation, but whenever the child comes back to us, whenever we are contemplating a change in treatment. Estimation of risk, as has been mentioned before, depends on all these clinical criteria, both at onset and follow-up. It depends on histopathology, and it also depends on treatment. So response to treatment is a good outcome and has good prognosis, but no response to treatment has a bad prognosis. And in adults, we now have a risk prediction tool, which also includes, along with all these features, also includes the age at biopsy, the race, the use of different immunosuppressant treatments to give you an assessment of risk. And very recently, this has been updated for use in children. And if you look up this citation, the web link is also present here. So maybe this will be something useful for us in pediatrics when we are trying to tailor make our treatment regimen individually according to the patient's manifestation and profile. Now, there are some new things on the horizon. Podocytopathy has been shown to be a relatively bad prognostic factor and has been suggested to be added in the MES-C classification. I've already mentioned that episodes of gross hematuria, sometimes leading to AKI due to the tubular blockage by RBC casts, can cause tubular injury and can lead to progression and chronic damage. There are different types of complement pathways involved, and therefore there is research on complement blocking, which may or may not be useful in management of this condition. There is also a lot of research on what exactly promotes the abnormal response and the pathophysiology and the different hits that gives rise to the ultimate phenomenon of IgA nephropathy, and whether this can be interrupted during this pathway at any stage. And there's a lot of interest in genetics to try and assess whether there is anything in the genes which makes some patients more susceptible to develop severe disease compared to others. So many drugs have been tried. What is furthest en route to probably becoming a recognized therapy is the targeted release budesonide. And if you think about it, in the second patient I presented, who had macroscopic hematuria every time he had a cold, but had no abnormalities in between. So it seemed illogical to give him a chronic treatment. But if you had a treatment like this that would protect the mucosal exposure to allergens, this might be ideal for many of our pediatric patients who present like this with symptoms whenever they have URTI or a gut-related infection. Other drugs also have been used, such as rituximab, eculizumab, and till date, they have not been shown to be particularly effective. So to summarize, pediatric IgA nephropathy is an acute disease if we can catch it at an early stage. Many of our patients have acute proliferative, mesangial, and endothelial proliferative changes, which are potentially reversible. Even crescents have been shown to be potentially reversible. Although spontaneous resolution has been documented in a good number, but we still cannot differentiate at onset which are the patients who will have spontaneous resolution. And therefore, this whole issue of risk assessment based on many different parameters. So I come back to what I started with. There is a lack of good quality large RCTs in children, and we do still have to individualize management based on estimated risk and potential of reversibility. And I hope I have shown you some examples, how we can do that. In presence of risk factors and reversibility, early biopsy in presence of risk factors, early biopsy should be done. And if there is reversible changes, early aggressive therapy is also indicated. Until now, what we have in our armatorium are ACE inhibitors, steroids, and some immunosuppressants. However, we await long-term good trials. The prognosis, we have to remember, depends not really so much on the presentation, but more on the response to treatment. And in this condition, we are still in the stage of evolving knowledge. This condition is relatively rare in most parts of the world. So it is difficult without multi-center, multinational trials to have enough patients for studies. We also need to follow up very long term because progression occurs over decades, and therein lies the difficulties. Thank you.
Thank you, Susmita ma'am, for the excellent talk. It was really a clinical oriented discussion. It was an excellent presentation. We'll move on to the next speaker, Dr. Roshan George. We have few questions for the topic. We'll be taking up the questions at the end of the session. So Dr. Roshan George is the next speaker, and she will be talking on guidelines on ANCA-associated vasculitis. She is Associate Professor, Division of Pediatric Nephrology at Emory University, Atlanta, and she is also a Director of Pediatric Nephrology Fellowship Program and Director of Transplant Quality, Pediatrics Solid Organ Transplantation, Director of Renal Transplant and Transition Program. Her area of interest is towards transition of care, biomarkers for detection of early rejection in transplant, social determinants of health and healthcare disparities, quality improvement and medical education. She has received Award of Excellence. She has received Award of Excellence in Patient Satisfaction by Emory University of Atlanta, and she is designated as a Fellow of American Society of Transplantation in the year 2019. And she has contributed to a lot of journals and publications to add on. Over to Dr. Roshan to deliver a talk.
Hello. I'm just pulling up my slides. Are you able to see it?
Yeah.
Excellent. Thank you so much, Dr. Kalaivani and your team for inviting me and putting together this wonderful webinar. And thank you to all the participants for joining us on this Saturday. So I'm going to talk about the guidelines and treatment of ANCA-associated vasculitis. So objectives today are for us to understand the pathophysiology and the diagnostic guidelines of this ANCA-associated vasculitis, know the trials in the treatment of ANCA-associated vasculitis, and there are several, but continuing on the theme that Dr. Susmita mentioned, not a lot in pediatrics. We will be mentioning some of the pediatric differences as we talk about these. And then finally learn the current framework for management from results of these trials, kind of putting it all together. So let's start a little bit with the history, the pathophysiology and diagnosis of ANCA-associated vasculitis. So identification of the three primary ANCA-associated syndromes evolved from the classic PAN or polyarteritis nodosa, which had been described quite early in 1886 and 1908, that was earlier compared to ANCA-associated vasculitis syndromes. In 1930s, in early 1931, Klinger described GPA, but it was Wegener who described more specific findings of this syndrome. In 1951, Churg and Strauss described the Churg-Strauss syndrome, and more recently, 1985, Savage and colleagues described MPA. The ANCA antibody itself was first described in 1982 in the case of a segmental necrotizing glomerulonephritis. The first international ANCA workshop in 1989 first delineated the standard immunofluorescence technique to test for ANCA in a kidney biopsy specimen. And in the second international workshop was when the perinuclear ANCA or p-ANCA was accepted. And then these antibody assays were used in diagnosis of ANCA glomerulonephritis. So as you can see, many of these diagnostic features that we use now are pretty recent relative to other conditions. And this article actually talks quite in detail and is quite fascinating about the history of ANCA vasculitis in rheumatologic disease. So if we think about the characteristics of ANCA vasculitis, obviously it's associated with ANCA, and it affects predominantly the small-sized arteries. Most of these have very similar features on the kidney histology, which is characterized by focal necrotizing, often crescentic, but pauci-immune GN. And most common affected organs, as you all know, are the respiratory tract, upper and lower, and kidneys. So the three major parts or subgroups of ANCA-associated vasculitis are GPA, MPA, and eGPA. So GPA is granulomatous with polyangiitis, which is our old Wegener's disease. MPA is our microscopic polyangiitis. Then we have our eosinophilic granulomatous with polyangiitis, which is eGPA, which used to be our Churg-Strauss disease. There is also a renal limited vasculitis, which is kind of a fourth entity, but very similar in presentation in terms of the GN part. And it's sometimes just grouped into the GPA piece, but there is no pulmonary involvement in that. So as you can see, in the broader umbrella of all the vasculitis, which affects different size vessels, the ANCA-associated vasculitis is present in this little box here, the three conditions that we talked about. So as we look at what causes this, let's start by thinking about our antibodies and how this present in terms of association with each of these. So when we look at the vasculitis, there is association with MPO ANCA or PR3 ANCA. And all of these, the PR3 ANCA or MPO ANCA, are from different origins. As you can see here, MPR3 is from chromosome 19, MPO from chromosome 17, and they all have different kind of pathways or features. As we talked about in the subgrouping, there is also this thought that ANCA vasculitis should potentially be classified according to this specificity, whether it is PR3 ANCA or MPO ANCA. And that is also because there is a little bit difference in clinical presentations, such as there is a higher relapse rate with patients who are PR3 ANCA positive, or higher mortality rate in patients who are MPO ANCA positive. And there is some genetic studies that say that the clinical phenotype relates more with that ANCA specificity. Looking at what exactly drives the pathophysiology, again, a lot more needs to be done in this area, but there seems to be an interplay between immunologic, genetic, and environmental factors. What happens is the neutrophil is the driver of the initial cascade of events. There is activation of PR3 and MPO antibodies, which interacts with ANCA, and the ANCA activation or production is a little bit of a mystery. It seems like the interplay of all these factors we mentioned leads to this activation. And when ANCA activated neutrophils combine, or there is that cross-reactivity, then there is deposition and proliferation through the endothelium, and there is an activation of inflammation. This path is actually potentiated by the alternate complement pathway, and specifically by complement 5, activated complement 5. The MAC complex actually does not have a huge role to play in here as compared to other conditions like HUS, but it's complement 5 activation that leads to potentiation of this pathway specifically. And then when this goes into the interstitium, there is more and more granulomatous formation. So when we go on to look a little bit deeper into the pathophysiology, we see that in here there is the pathway we just talked about with the neutrophil activation and C5a chemokines and complement activation, which leads to necrotizing vasculitis. But there is also proposal that there are T cell activation, which is an additional pathway that is coming to prominence now. These are effector T cells and effector memory T cells, which are more active and are not regulated by the Tregs. And so there is more ANCA production and production of pro-inflammatory cytokine, which activates the neutrophils even more and causes a vicious cycle, making this cascade of events more and more positive, increasing tissue inflammation, and then further down the line, triggering the B cells. And why all of this is important is that these are specific pathways which are targeted by the treatment that we will be talking about. Clinical features are multi-system. As you all know, the patients usually have two kinds of presentation. Sometimes it's very insidious, where the non-specific symptoms are there for weeks to months, such as fever and arthralgias, myalgias. The lesion may involve, as you see in the picture, anywhere from the nervous system with strokes. This is a little bit less common in children, but in adults or in older teenagers, you can have wrist drop or foot drop, eye involvement, hemoptysis, cough. The kidney involvement is much more common in pediatric patients, and as we know, it can be the usual urologic abnormalities, the urinary abnormalities with hematuria, proteinuria, but with also abnormal kidney function. And then skin presentation in some of our patients. GI presentation can also be seen. One point here which differentiates some of the pediatric patients is that cardiac involvement is more common in children, and the lung and cardiopulmonary symptoms are more commonly seen than in adults. Some of those patients also present very much with non-organ threatening manifestations. These are sometimes younger patients and can be women, but these are chronic, long recurring conditions, and these can cause other respiratory deformities that we see, such as saddle nose deformities. If we look at the lab work that is important in diagnosing, so you get a good history, you do a physical exam, go through all these systemic symptoms, and then we start with some basic labs, as we do for all our patients, our urinalysis, renal function, CBC, where we usually see leukocytosis, thrombocytosis, and anemia, which is chromic normocytic. And then you see elevation of your acute phase reactions, such as ESR and CRP, which is very non-specific. Other lab tests are important to exclude other conditions which can sometimes appear to have overlapping symptoms. So important to rule out lupus, anti-GBM, complement assays. Really critical to make sure there is no infection, specifically hepatitis or HIV, and ordering other screens such as TB screen. In adults, cryoglobulins are important to assess. Because of the insidious nature, sometimes it takes time to diagnose these patients. Many of these patients are misdiagnosed as malignancies, infections for a long time before the exact diagnosis is made. So it's important also to think about the specific testing that we base our diagnosis on, which is ANCA. And in the clinical setting, this can be detected using an immunofluorescence, which looks at your assay. But the ELISA, looking for PR3 and MPO, is what is more preferred in patients with suspected GP or MPA. Immunofluorescence assay is more sensitive, but ELISA is more specific. So the diagnosis finally, once you do the screening test with the immunofluorescence, is based on the ELISA. Imaging testing, specifically in pediatrics, is important with both chest X-ray and CT scan. So if the chest X-ray gives you proper findings and you are comfortable that patient's clinical status matches up with that, then I think that should be fine. But a lot of times, especially in pediatric patients, there are hidden features such as undetected nodules or cavitations, which are very hidden. And so it's important and recommended usually to get further imaging such as a CT scan. Now, depending on the symptoms, if you have specific sinus-related problems or eye-related problems, then additional imaging can also be obtained. As with anything else, we would diagnose it if there are renal manifestations with a renal biopsy. And again, the renal manifestations, most commonly proteinuria, significant hematuria, and change in renal function leads us to get to it. But either ways, the diagnosis should be confirmed by whichever site is active with the disease as per the guidelines. So here, as you can see in the biopsies, there's a lot of segmental necrosis. Here there is crescent formation, which is pushing on your glomerular tuft, and outside extraglomerular necrosis that you can see with some mesangial hypercellularity there. So the next step, once you have already made the diagnosis by doing all of these first steps, is to assess the disease severity, because a lot of the treatment depends on how severe and how organ-threatening the disease is. So there are two forms of disease broadly, the ones which affect the organs, and many of these are very life-sustaining organs. So active GN, pulmonary hemorrhage, cerebral vasculitis, neuropathy, orbital involvement, GI bleeding, and then cardiac issues. These are all your more serious forms and increased or higher disease severity. And the non-disease organ-threatening disease or non-life-threatening disease are more localized with rhinosinusitis or just pulmonary nodule, which is not causing any lung symptoms or lung progression of findings. However, it's really important to state that this can also result in long-term damage and morbidity for these patients. So even though it's not life-threatening, it's burdensome. So if we go on next, you've diagnosed it, you've assessed the severity of the disease, then we jump into the treatment. And there are several trials in treatment of ANCA vasculitis. As we just initially mentioned, even the diagnosis criteria are not that old. So the treatment guidelines are still ongoing in its development. We have the two-stage approach, like in a lot of our serious diseases. You have the induction phase, which usually lasts in the first 3 to 6 months. And the goal here is to rapidly decrease your inflammation so you can get into remission. And the second phase is the maintenance phase, and this is a prolonged phase, 24 to 48 months. And the aim there is to prevent disease relapse and reduce long-term damage as much as possible. One thing I like to mention right here is that there is a condition where it's a refractory disease, which is no improvement or worsening disease activity by 4 to 6 weeks. This is within that induction phase itself, you have worsening of the disease. And there is relapse, which is a second part of it, which happens after your maintenance phase is complete. So in refractory disease, it is recommended that you should switch the initial induction agent, and we will go over some of the induction agents. This is also the recommendation for relapse. If you have completely finished your maintenance phase and had come back to a relapse phase, then it might be wiser to start with a slightly different induction agent for your second relapse. So let's dive into it. There are different trials for induction therapy and maintenance therapy, and this was a nice timeline I found that was there in the Renal Fellow Network, and this is something just a little on the side I'll mention for trainees or learners who may want to look at this. It has really nice comprehensive discussions on different nephrology-related topics. So we will go over some of these studies a little bit more in detail, but we will pull it all together because it can really, all these names and abbreviations can get confusing. So let's start with the induction for our treatment of ANCA vasculitis. And again, the goal is that we have to get the patients into remission. So starting in 1970, cyclophosphamide and glucocorticoids, or steroids, were found to be very effective in ANCA vasculitis. So glucocorticoids, high-dose pulse steroids, usually given for 3 days, followed by a taper. And in 1992, there was a study of 158 patients with GPA, which summarized that the outcome could be dramatically improved if the treatment was done daily with cyclophosphamide and glucocorticoids. They did find in this patient population that, or in this cohort, that there was significant disease-related and treatment-related morbidity. And as you can see, 13% of these patients died, 86% had irreversible features of the disease, and 42% had side effects of treatment. This is one of the places where you also see, I thought this was interesting, Anthony Fauci, who was actually the lead and one of the senior people doing this study, and has made definite impact in our field as well, in addition to the infectious disease field. So that was the starting point with adding cyclophosphamide. But then the question came whether the route of cyclophosphamide, whether oral or IV, would be better, which would be a more effective agent. So in 2009, the Cyclops trial was a randomized control trial, which was done by the European group, European Vasculitis Study Group, which involves a lot of centers in different countries, compared oral and IV cyclophosphamide induction. And they found that the oral cyclophosphamide had lower rates of relapse, but the total dose was significantly more than IV cyclophosphamide. So IV cyclophosphamide was inducing remission and had lower rate of risk, such as leukopenia and infection, but most likely because the total dose was less, there was more relapse in that population who received IV. But they didn't truly have enough power to detect the difference of relapse, even though when they just looked at the data, the relapse seemed to be lower in the oral cyclophosphamide group. So given that kind of nuance, it has been felt that IV cyclophosphamide in the long term would be better for inducing remission faster and causing less side effects. And this was a study over here in 2009. Now, looking for different agents became important because cyclophosphamide, as we know, has side effects over long-term use. So these two trials, RAVE and rituximab, looked at rituximab as an induction agent instead of use of cyclophosphamide. The dose they used was 375 milligram per meter square once a week for 4 weeks. The RAVE trial compared ritux and cyclophosphamide, with each treatment was given in addition to glucocorticoids, and this showed that it was non-inferior to cyclophosphamide for new onset ANCA-associated vasculitis. Actually, they, in the study, thought that it may actually be superior in relapsing ANCA-associated vasculitis. So if it was new onset, it was similar, and if it was relapsing, it was better to switch over to rituximab if cyclophosphamide was used first. It was also noted that in this RAVE trial, there were sicker patients who also had alveolar hemorrhage, so they were on ventilation, and there were kidney failure with high creatinine, again, all adult patients. The rituximab trial showed similar data to this RAVE trial, with both treatment groups demonstrating that there was sustained remission, but there was again higher adverse events. And these patients in this trial actually received IV cyclophosphamide as well, and that is the difference between these two trials, because the RAVE trial, the rituximab group did not receive cyclophosphamide. So both of these trials, interestingly, was published in the New England Journal of Medicine, literally the same issue. They both moved the field towards another option for our patients, especially the ones who have side effects from cyclophosphamide. Then the next piece, which is written about a lot and studied not that much with limited studies, is plasmapheresis. So the study that initially was done was in 1991, which just concluded that plasma exchange provided additional benefits for patients who had severe renal disease and were dialysis dependent. But it was less pronounced when they followed up those patients. So the MEPEC study in 2007 that was published also looked at this category of patients who had severe kidney dysfunction, were end-stage kidney disease, and high serum creatinine. And it did find that initially there was benefits from plasmapheresis, but over long term, the difference disappeared. So the next study that looked at plasmapheresis, the PEXIVAS study, more recent, was a 2x2 randomized trial which compared plasmapheresis and standard versus low-dose steroids. So they looked at plasmapheresis and also the steroid, and this was also severe patients who had pulmonary and kidney disease. So the patients received either cyclophosphamide or rituximab, all of them, and that was left to the physician to decide. And there was no difference in efficacy between the two glucocorticoid group, but obviously there was less infection in the low steroid group in the first year. So that helped people to try to wean down the steroids a little bit faster. And over time, after 2.9 years of follow-up, almost 3 years, the primary composite endpoint, which was death or kidney failure, occurred in 28.4% of the plasma exchange group and 31% of the control group. So literally just was like the prior studies, which showed that not a lot of difference happens if we do plasmapheresis or not. Now, there were some criticism or some concerns that maybe the plasmapheresis that was done was not long enough, or whether more plasma use would have been helpful. But most of the objective data doesn't show a huge difference. But obviously, if there is significant reduction in kidney function, significant progression of the disease with rapid decline in kidney function, then this is something that is added on to the regimen in most places. After this PEXIVAS study results were made public, this article came out saying that maybe there is an movement to end plasmapheresis for ANCA vasculitis. But honestly, even in this perspective piece, the authors wrote that this practice is much entrenched and will not change immediately. And we do see some immediate benefits in our patients. So, you know, it is easier for us to get to that step than just sit and watch declining kidney function in front of our eyes. So that is kind of the quick tour of the induction therapies and trials, and we will jump into the maintenance therapies. Now, maintenance has been more long-term so that relapse doesn't happen. And different agents have been used. Methotrexate, this was used early on as already rheumatologic conditions have this as one of their protocol medicines. So familiarity with using it. It's a folate analog inhibitor, and IV or oral dose can be used. There are several side effects to this, so it's not the most popular. And azathioprine, which is a purine analog and easier to dose orally, started being used more. That has its own side effects. And when a French group compared this methotrexate to azathioprine, there wasn't any difference between the groups. So more commonly now, azathioprine becomes used. And then there was this Cycazaram trial in 2003, which showed that cyclophosphamide could be safely transitioned to azathioprine for maintenance. A few years later, IMPROVE trial was published, which suggested that MMF was not as effective as azathioprine. So that kind of established for maintenance therapy, the superiority of azathioprine. Now, is there a role for rituximab for maintenance? So more recently, the main RISTEN trial in 2014 showed that the rituximab had better sustained remission at 28 months than azathioprine. And the rituximab trial is also investigating the role and suggesting the same, that prolonged remission is possible on rituximab. And this could be something to think about in patients, especially if adherence is an issue and they're experiencing side effects from azathioprine. Duration of maintenance therapy is still somewhat being codified or refined, because it's still unclear what would be the best duration as you balance out the reduction in relapse with the side effects from all these agents. Long-term follow-up of maintenance therapy trials have shown that after you discontinue the maintenance immunosuppression, there is higher rate of relapse. In a study from Cleveland Clinic, patients who had GPA and were treated with azathioprine or methotrexate for more than 36 months showed that there was reduced relapse as compared to those who were treated between 18 to 36 months. And that was quite a significant reduction. And that's why some even suggest going all the way to 48 months with maintenance therapy. The REMAIN trial actually looked at that and continued azathioprine and prednisone treatment for 48 months and was shown to be more effective in relapse prevention than withdrawing it in 2 years. And there was a decrease in both major and minor relapses and better renal survival. But the important thing is to customize this for your patient and see what the balance is between side effects and what the predictors of relapse are. There are specific things that cause a person to be a higher risk for relapse, including younger age for the patient, if it's a PR3 ANCA, and also another very unusual, or we should say something that goes back to the interplay of immunologic, environmental, and infectious agent, is nasal carriage of Staph aureus. So in that vein, it becomes important to think of trimethoprim sulfamethoxazole. This is a good agent to give to prevent pneumocystis in pneumonia as a prophylactic agent, but it also helps with prevention of or treatment of some of the infectious agents that are somewhat thought to cause relapse. So some studies even suggest, and those are not randomized control studies, that just single agent cotrimazole can actually help with reducing relapse in some of these patients. Obviously, it is very useful for preventing PJP pneumonia, and patients who receive high immunosuppressive medications or strong immunosuppressive medications should be placed on it. The duration of this, again, is controversial. Some suggest 6 months after the discontinuation of the induction agents. Important really to monitor bone health. There are patients, especially pediatric patients, who have a higher risk for fractures and long-term bone-related abnormalities. Also vaccination, making sure they have no risk for other infections, and monitoring growth, nutrition, and development, and also getting some good discussion started about fertility, especially if patients have received high dose of cyclophosphamide, as we know it's associated with infertility. There are some novel approaches, such as using combined rituximab and cyclophosphamide. Abatacept use is another one that people have been trying. Complement inhibition, which is using selective C5a receptor inhibitor, which are all in the works, and nothing has been out suggesting that this would replace any of the existing therapies. So now, trying to put all those things together, what do we do when we have a patient? We have to start by our first steps, which is our history, physical exam, and any of our helpful labs or imaging, biopsy to diagnose ANCA-associated vasculitis. The next step is to assess disease severity, because based on life-threatening or vital organ involvement, we are and I'll show you an algorithm of this in a minute, going to classify them to what treatment they should be receiving based on their risk stratification. Then choosing the appropriate agents for both induction and remission. And it's really important to monitor long-term for complications and to follow these patients up very closely. Most of the follow-up studies are just a few years out, and there is a lot of reasons for these patients to be at high risk for multiple complications, including end-stage kidney disease, also malignancies in the future. So really important to continue the follow-up. So based on the kind of kidney disease, whether it's mild to moderate kidney failure, or whether it's severe kidney failure, there can be different ways of treating these patients. Again, this is divided into what kind of ANCA positivity they have, and whether you start off induction, most of that part is common, rituximab and your steroids, or cyclophosphamide with your steroids. Some, if you have really not a lot of organ involvement, could be just MMF with steroids, but most of the times using one or the other, rituximab or cyclophosphamide, is recommended. If you achieve remission, then you start maintenance therapy. And if you don't achieve remission, then you go on to the next step by switching over what you have here. As you note, none of these actually talk about plasmapheresis in this. Now you get into this part where it's severe kidney involvement or dialysis as presentation. Now we have these agents, IV rituximab with cyclophosphamide. And here, even though it doesn't say in these slides specifically with plasmapheresis, this is where, if you feel compelled by how the patient's condition worsen, that could be something to try. And again, the remission achievement leads to maintenance therapy. And here you can use both rituximab or azathioprine, as more studies now are talking about rituximab. That is mentioned first here. There are different algorithms that specify these treatment pathways. So again, customizing for your patient's needs. So finally, in summary, we know that within the last few decades, the knowledge that we have gained has gone significantly from a disease that was very high in mortality to something which has now become a chronic relapsing and remitting disease. Obviously, we are not satisfied to see our pediatric patients experiencing this burden of chronic morbidity. So we want to continue research. It would be really wonderful to have more RCTs in pediatric patients, which would need to be multi-center because of our numbers. At this time, there are some adult studies, one or two, which have included just a handful of pediatric patients, but not much has been done in that. So trials need to continue to go on. With that, I will stop, and thank you so much for your attention, and I'm happy to take questions.
Thank you, Dr. Roshan. It was an excellent session, and you made the difficult topic very easy. Now we can move on to the question session. Susmita ma'am, you're there around?
Yes, I am. You can hear me?
Yeah, I'm able to hear you, ma'am. Can we go ahead with the questions?
Sure, yeah.
So the first question is, how do we diagnose IgA nephropathy in low-income country without a renal biopsy?
You can't. Simple answer. I suppose if you have macroscopic hematuria in pharyngitic, that's the most common diagnosis, but it also could be, I don't know, it could be Alport's, it could be other things. You have to have a renal biopsy. IgA nephropathy is a diagnosis of a biopsy. The diagnosis is made by biopsy.
Okay, and the next question is, do you manage HSP nephropathy and IgA nephropathy differently, or if so, how?
So HSP nephropathy I said that IgA nephropathy is an acute condition in most children who present early. HSP, in fact, is an acute condition it is even more of an acute condition because almost all children will present at the very onset. There are other systemic features also, but yes, as you have said, the histopathology is just like IgA nephropathy, and gradually the classification of the histopathological grading, etc., is also moving in the same way as IgA nephropathy. The outcome, though, is very different. So where you have 20%, 30% of children who progress in IgA nephropathy, there is a much smaller percentage who will progress in HSP nephropathy. So the majority of patients will actually have, even if the majority will not have renal manifestations. Even if they have renal manifestations, the majority will get better, and there is a very small percentage of patients who will actually have progression and ESRD. And therefore, the guidelines or what the consensus is also a little bit different. So with severe changes, of course, like if you have HSP nephropathy with nephritic changes, nephrotic changes, nephrotic changes, hypertension, you still go for an early biopsy. But if you have very minor changes like microscopic hematuria, proteinuria, in HSP nephropathy, the advice is to go for biopsy only if there is persistence after about 4 weeks. And then to go for aggressive treatment depending on the findings. One thing to note is that studies in HSP nephropathy seem to indicate that steroids do not have any role in prevention of nephropathy, but they do have some role in preventing patients who have nephropathy in preventing progression. So there is a role for steroids in patients who have developed established HSP nephropathy, but not as prophylaxis. So I think that is the difference, that it is a different disease. The outcome is different. The incidence of progression of ESRD, of severe changes, is different. And steroids are given if there is renal involvement as treatment and not as prophylaxis. As you know, many people, there are many studies that have looked at that as well. I don't know if that answers your question. I hope it does.
So like I had a similar question running in my mind. Only thing is like HSP nephropathy, they land with CKD, the proportion is little less, right, ma'am?
Yes.
But
Yes,
if
but
they have
if you have severe changes, you would still give similar treatment. So if you have a severe clinical manifestation with the severe grade of histopathological changes, you would still go for steroids and immunosuppression. Steroids, there is proof that there is improvement, but with different immunosuppressive agents, there is no real data saying which one is better or which one works.
Okay. I just have a child who's 14 years who actually presented with typical features of HSP rashes. And the initial 2 weeks, actually, she did not have any features of nephritis. Subsequently, she then developed hematuria, microscopic hematuria, then hypertension. And she was a newly diagnosed diabetes. So she's falling into a category of metabolic syndrome. She has hypertension, then diabetes, and she had nephropathy, obesity is there. Right. So like we gave her steroids, like she's been on steroids, a good dose of steroids, but she has never attained remission. She is still proteinuric. She is typically behaving like a nephrotic syndrome with hypertension.
And
so like we
biopsy
have given good dose of steroids. What, ma'am?
Biopsy findings?
Biopsy is minimal mesangial proliferation, which was done in the early part when she landed up with microscopic hematuria after the onset of rashes 2 weeks down the line. So at that time, she had minimal mesangial proliferation, no crescents, but till date she is edematous and she is having significant proteinuria, nephrotic range protein.
Did you try adding any immunosuppression?
She is on actually now, like we started on enalapril and she is on mycophenolate.
Okay. So, in both these diseases, both in HSP and in IgA nephropathy, there is, in all the studies, there are a group of patients who do not respond. and who continue to progress or have, clinical manifestations despite different therapies. So these are, when you look at the studies, they tell you so many percentage got better and so many percentage didn't, and they look at statistical differences between the two groups. And if there is a significant difference, then they say, yes, go ahead and use this therapy. But there is always, for the individual patient, that patient might fall into the group that did not respond. And unfortunately, in both these conditions, there are patients who do not respond.
What is the role of tacrolimus calcineurin inhibitors in HSP?
All of these drugs have been tried. All of these drugs, there are small studies that have looked at, but they are not RCTs and they are not large studies. So it's difficult to choose which one.
The problem with her is when we give tacrolimus, her edema is sort of okay, but she is still proteinuric. But the problem is she lands up with AKI. There is like gradual increase in her creatinine. Once you stop the tacrolimus.
Right. How many months is she on medications now?
It's almost 3 months now.
Okay, so it's still, in these kind of diseases, still fairly early, I think.
Okay. So, it's more than 3 months. She is still proteinuric, nephrotic range. It has never come down. The nephrotic range proteinuria has never come down.
I showed you was nephrotic for a long time, which is why we kept adding. We added on MMF. We increased her RAS inhibition to maximal possible levels, and it is only even at 1 year she had persistent proteinuria. And it is now she's almost at 2 years, and it is only now that has got a normal protein creatinine ratio. So 3 months, I think, is early in in this group of diseases.
So what is the role of
renal function?
What, ma'am?
Renal function is stable.
Renal function, that's what, like once the calcineurin inhibitor has been added, her creat went up to 1.2. So I tapered the dose and kept it to the minimal. And so I just wanted to know what is the role of combination drug of calcineurin inhibitors and mycophenolate. Will that help?
I would have to look it up. I can't tell you offhand. I have seen studies in HSP nephritis using different agents, but specifically this combination, I can't remember offhand.
Okay, fine, ma'am. Thank you so much, ma'am. Like I had my personal doubts, so got it clarified as well.
You must have looked it up already. What did you find? Did you look it up?
We looked at, but like literature says you can use combination drugs. But the thing is, when we use tacrolimus, she becomes a little edema-free, but her creat is increasing. Combination drugs can be used. So what I have put her on a little lower dose of tacrolimus than what is required, and a good dose of mycophenolate. So this combination drug, and she is on a good dose of steroid. She is almost on 30 milligram of omnocortin. But she is on alternate day. She's not on daily dose. She's little obese. She's already having this metabolic syndrome also.
Sure, yeah. Dr. Roshan, any ideas?
No, I was just thinking that, sometimes it is also a point of, are you willing to sacrifice a little bit of her renal function to prevent edema? And so sometimes it is preferable to go into a little bit of CKD and prevent if the edema and proteinuria causing side effects, specifically infection or thrombosis or anything else that you're seeing, or significant quality of life issues. And that would, there are, just like Dr. Susmita said, there are some patients who just take a long time to get to that point, or sometimes never get to the point of remission, unfortunately. Because there are patients who do progress in this category to end-stage kidney disease, right? Not a large population, but there are some. So hopefully you're still early and you'll get to a point where her numbers will change or her response will change.
Okay.
But try an ACE inhibitor also if you don't have it on.
No, she is on AC inhibitors. That's the reason I just tapered the dose of tacro, because 2 combination drugs of nephrotoxicity.
Yes.
And the next question is again to Dr. Susmita. For a patient with M1E1S1 T0, CO had severe presentation of proteinuria with nephrotic range, did not respond to methylprednisolone pulse oral steroids. How do you manage this patient further?
So M1, S1?
M1, E1, S1,
E1,
E0, C0.
T0,
And
C0.
C0, no presence. Yeah.
Okay, and clinical presentation?
Nephrotic range
Nephrotic
proteinuria.
range proteinuria.
They
Has
have
had methyl
ulcer.
penicillin.
And they have
Has had
switched over to
methyl
oral
penicillin
steroids,
and
no
oral
response.
steroids.
Yeah.
So, yeah, so it is a similar kind of discussion, really. How long has the child been treated? Is the child on maximum possible ACE inhibitors? You would, if say a month of daily steroids has been crossed and the child is still proteinuric, you would, I think, consider adding a second line agent. Like, I think MMF is one of the most popular agents, but in IgA nephropathy that has been tried, but there have been also reports of, as I showed you, CNIs, cyclophosphamide, etc. So I think a second line agent, if steroids have not has been given a decent amount of time and have not worked, then a second line agent and maximizing ACE inhibitors.
Okay, and in these patients, like to our second question as well as for the third one, does repeat renal biopsy is going to throw any light?
If you've got the child on maximum treatment, you're not going to, and the child has not responded, you are, you're going to try to escalate the treatment anyway, right? It's only on the long term when there is persistent proteinuria and you want to assess whether, there is something left to treat, whether aggressive immunosuppression should continue, or is it just a chronic kidney disease now and that is causing the proteinuria. That kind of time frame is, I think, when you would look at a renal biopsy. When you're trying to think, should you be stopping your immunosuppression? Should you be escalating it? Should you be converting just to supportive therapy with RAS inhibition? That is the time, I think. I would not find much value of doing a repeat biopsy very early on.
Okay. Okay, fine. Thank you, ma'am. And the next question is, how do you explain the finding of AZA may be a better than a MMF for maintenance in case of vasculitis, ANCA-associated vasculitis?
Thank you. Honestly, I cannot explain it. I had myself thought that that was really interesting, and speculation is that maybe there is some part of the immunologic pathway that is better blocked by azathioprine, even though for other immune conditions such as lupus and all that, we find that MMF is somewhat superior to it. So it's really not well defined or clear why that is a better agent. So I think we need to keep looking and digging in more in the immune pieces there.
Okay. The next question is again to Dr. Roshan. Do possible to use tacrolimus in patients who no well respond to rituximab and glucocorticoids and induction therapy?
So most of the studies have not looked at CNIs for these, like looking mostly at MMF or azathioprine, but we know that in our patients who have ANCA vasculitis and get their transplant, they are on CNI, but they also have like some other antimetabolite agent most of the time, MMF or azathioprine. So in those patients, actually the outcomes are not different from controls who have never had ANCA vasculitis. So it's not a big push area that has been studied, and I feel that if we are basing our management on evidence, then it's not evidence-based to use this, at least at this point. But if these patients are not responding to rituximab and glucocorticosteroids, then it might be smarter to switch to cyclophosphamide or even trying azathioprine or something else than trying to do tacrolimus at this point. Not to say that something may not come in the future, because as I said, in transplant patients, those patients are doing fine with that, but they also have some other antimetabolite agent in them.
Okay. Thank you, Dr. Roshan. And the next question is again to Dr. Roshan. In a patient with ANCA positive vasculitis, if the child has progressed to ESRD, requiring dialysis, but having episodes of pulmonary hemoptysis suggesting active lung disease, should we continue immunosuppression and how long?
Yeah, that's a very good question. And I would say that, it's a bit tricky. Yes, you should continue immunosuppression. There are also suggestions for those patients. Would it be worthwhile to do plasmapheresis, especially if you are dialyzing using a catheter anyway, so you have access? So trying a, good 7 to 14-day regimen, would that have any immediate benefits? Because more severe conditions were when, like refractory renal and pulmonary cases were when that was tried. So yes, continuing immunosuppression, at least for those patients, should be a consideration and should be tried. How long is very debatable. Most of the times for all of this, including induction therapy, is till active disease subsides. They also talk about making sure the ANCA levels are normal or undetectable, so continuing it till that point. One point I will make is that in our dialysis patients, many of them are not able to metabolize these antimetabolites well. So it's important, especially if you're using MMF or azathioprine and cyclophosphamide, to monitor for side effects, especially cytopenias in these patients. And for some, we even actually do AUCs to make sure we are not overshooting the drug levels for these patients, especially with end-stage kidney disease and the dialysis variability they may have.
Okay. There are a few other questions in the mail list. We'll just take few questions alone. For Dr. Susmita, does omega-3 fatty acid help in IgA nephropathy?
The recent evidence suggests that it does not. So some of the initial Japanese trials suggested that it did, but looking at worldwide studies, it doesn't. And KDIGO, in fact, does not suggest it except for patients who do not respond to other things. Even the pediatric Japanese guidelines, in fact, do not suggest fish oil anymore.
So what is your personal suggestion?
Sorry, fish oil?
What is your personal suggestion of adding omega-3, ma'am? Do you add to your...
I think, sometimes when we do not want to treat patients, but patients are very anxious, we sometimes give patients omega-3 because we think it's not causing any harm. But certainly there is no evidence to show that it does any good.
Okay, fine.
Can I just come back to, I just thought of adding to your question about HSP nephritis, who is not responding to the initial immunosuppressants and even to a multi-immunosuppression regime. There are also studies that have looked at IVIG and also studies that have looked at rituximab. So in a patient where, renal function is an issue with tacrolimus, you could consider these other agents as well in a difficult situation.
Okay. Thank you so much, ma'am. The other thing is, does tonsillectomy really help in IgA nephropathy children?
It's the same thing with tonsillectomy. There are Japanese studies that suggest that it helps in association with immunosuppression, not alone. But again, it has not been supported by worldwide data. I showed you a slide, remember, the Japanese guidelines, which suggested, of 2008 and 2015, which suggested things like tonsillectomy and anticoagulant therapy, etc. But then the same group in the most recent papers have said that current evidence, review of all current data suggests that none of these drugs, either fish oil or or tonsillectomy is to be recommended any further.
Okay. What is the prognostic indicators of IgA nephropathy? How quickly they can progress to ESRD? If so, is there any prognostic factors?
I think my whole talk was about this. So I was talking about clinical and biopsy, clinical factors and biopsy factors, and we combine them together to have a combined risk prediction for progression. And probably when the app becomes used by lots of us, when we become used to it, it'll be easier to have a prediction for children. Just like there is a prediction, the adult app, if you can actually use it yourself. You can key in all this data, and it gives you an assessment of what the renal function, what the risk of deterioration of renal function by 50% will be in X number of months. And you can ask for, the amount of time you want the risk to be calculated over. So if something like this is validated in children, that will be something very useful and something that has been a little more objective than trying to fix from patient to patient what the risk prediction is.
Okay, we are done with the questions, ma'am. Thank you so much, Susmita ma'am. Thank you, Dr. Roshan. You added so much of knowledge to the pre-existing topics, though it is a very common topic. We had a lot of queries in that too. It was an excellent session. Thank you so much, ma'am.
Thank you.
Thank you so much.
Thank you. Bye-bye. Thanks to the audience for listening on a Saturday evening. Bye.
Thanks for taking your time. Thank you, ma'am. Bye-bye, ma'am.
Bye.
Bye-bye. Good night.